Good morning, everyone. We'll start the day today with the endocrine lectures. May I request Dr. Arvindan Nair to please chair the session, sir? Now we'll start with the first lecture of the day, Management of Well-Differentiated Thyroid Cancer. May I invite Dr. Marathu Pandian to please start with his lecture. Thank you.
Good morning to all of you. Respected Chairperson, respected immediate past President Dr. M.J. Paul, Senior Faculty Dr. Deepak Abraham, Dr. Anjali, the Editor-in-Chief Dr. Pooja, and other delegates. At the outset, I'd like to thank the Organizing Committee of IAESCON 2022 for giving me this opportunity to talk on the management of well-differentiated thyroid cancer. Actually, I prepared this only for MS, General Surgery postgraduates. I couldn't see any one of them. Hopefully, I am going to cover this topic under these headings. So, having clinically diagnosed a thyroid nodule, how will you go about the further investigation to confirm your diagnosis and manage the patient? Of course, you have to go for baseline investigations, thyroid function tests, X-ray, ultrasound, FNAC, if needed, CT and MRI. So as far as role of X-ray in thyroid cancer is concerned, you have to take an X-ray neck and epilateral view wherein you can find out the classical 3 C's I used to say, the compression of the trachea, any calcification, and the curvature of the cervical spine. Suppose the patient has got associated cervical spondylosis and all, you will find difficulty in intubating, and you can inform the anesthetist that this will be a difficult case for intubation and all. And sometimes you can make out retrosternal extension. In the X-ray chest, if there are any metastases like lung secondaries, you can make it out. As far as the role of ultrasound in thyroid, it is done with 7 to 10 megahertz probe in an extended neck position. You can make out the anatomical extent, and any nodule which are not palpable can be made out by ultrasound. And the exact architecture of the nodule, whether it is hypo or hyper, you can make it out. And there are some features of malignancy which can be made out by doing an ultrasound. And the nodal status can be assessed. And sometimes you can use this ultrasound as a guide to do ultrasound guided FNAC. So I said there are some features in ultrasound to say it is a malignant nodule. What are they? Number one, there may be punctate fine calcification. The margins will be irregular. There will be absence of halo. Due to perinodular compression, there is a black rim of shadow which will be absent if it is a malignant nodule. And complex nodules with more solid portions. If you combine with the Doppler, you can have increased intranodular vascularity, the hypogenicity of the nodule, and associated lymph nodes can be picked up. And the same way you can make it out whether the given node in the neck is metastatic or not by looking at these findings. If the size of the node is more than 7 millimeter, and instead of oval shape, if it becomes round, think of secondary deposit, the node will be hyperechogenic, there will be cystic necrosis, and the hilum will be absent. You can find microcalcification in these nodes also. This picture is a metastasis to lymph nodes, so you can make out some calcifications within the node. And based on that, there is a thyroid's ultrasound guided classification from 1 to 6. Next the important investigation is FNAC. It has got an excellent positive predictive value in diagnosing papillary thyroid cancer mainly, has a sensitivity rate of 95% and specificity of 97.5%. You have to use a 24 or 25 gauge needle, making 5 to 6 passes in different directions. Keep on aspirating. The cells in the nodule will get transferred into hub of the needle, which can be pushed into the glass slide and either air dry it or apply a drop of cytofix and send it for cytological examination. As I said earlier, there are some indications where you can use ultrasound as guided in doing FNAC. For example, in a complex nodule, wherein there are solid and cystic portions, to target the solid portion, you can use ultrasound as a guide. And impalpable or non-palpable nodule can be targeted with an ultrasound. And nodules which are very posteriorly placed or very closely placed to the major vascular structures, in those situations, you can use ultrasound as a guide. Coming to the pathological features, in papillary thyroid carcinoma, the grossly you can see the hard nodule with a gray-white color due to microcalcification. You will have a gritty cut surface. In some instances, the primary tumor will be solid, while nodal metastasis will be cystic in nature. The classical feature of a papillary thyroid carcinoma, you will have the presence of papillae and unique nuclear features, which are defining the characteristic of papillary thyroid cancer. The papillae appear as a fibrovascular stalk lined by neoplastic epithelial follicular cells. The cytomorphological and nuclear features are very vital in diagnosing papillary CA. You will have an elongated oval nuclei. The nuclear chromatin is pale, optically very clear, and eccentrically placed, giving the orphan any nuclei. Sometimes you can have the infolding of cytoplasm causing nuclear grooving and pseudo-inclusions. Whereas follicular carcinoma, as you all know, we can't diagnose it by FNAC. The differentiated follicular carcinoma are identified by the signs of capsular and vascular invasion. Vascular invasion is defined by the direct extension of the tumor cells into the vascular lumen, tumor thrombi adherent to the vessel wall. Tumor cells vary in their histological differentiation but are differentiated from papillary carcinoma only by the nuclear changes are absent. You can make out the vascular invasion in this picture. Of course, you must recognize some of the variants in papillary thyroid cancer, because recognizing these morphological variants is to avoid misclassifying it and into a poorly differentiated variant cancer. The important variants are less aggressive tumors like follicular variant, micropapillary, encapsulated variety and trabecular pattern, whereas the high aggressive behavior tumor will be tall cell variant, diffuse sclerosing, columnar and oxyphil type. After having made an ultrasound and FNAC and confirmed your diagnosis, is it mandatory to have CT or MRI in all cases? Of course, if it is clinically very much mobile and all, I think there is no need for CT and all, but there are some selected indications like clinically fixed tumors, or if it is a medullary carcinoma, anaplastic carcinoma, in lymphoma for staging purposes, and to pick up local recurrence mediastinal nodes and the retrosternal extension, you can use CT or MRI as a guide. More importantly, the CT will tell you the adjacent structural invasion like tracheal invasion and all can be made out with MRI. The role of immunocytochemistry is seldom used in diagnosing differentiated thyroid cancer. Mainly it is useful in metastatic disease. Neoplastic cells are strongly immunoreactive with keratin, CK7, thyroglobulin and TTF1. Regarding molecular biology, it detects individual mutations, much useful in the evaluation of FNAC samples that are indeterminate and to assist in management decisions. Proto-oncogenes are mutations involving RAS, RET or PTC, BRAF and tumor suppressor genes like P53. This has been implicated in the development, progression and clinical behavior of differentiated thyroid cancer. RET PTC more common in children exposed to nuclear fallout, and P53 mutations, the chances of transformation into poorly differentiated carcinoma is more. BRAF and V600E mutation is increased incidence in recurrence, which is as high as 40%, and KRAS mutations are more common in follicular carcinoma. So after confirming your diagnosis, you must, before surgery, subject the patient for ENT examination to look for the nodal status. The role of tumor markers and radioactive iodine uptake studies are not meant for primary diagnosis, but useful in postoperative follow-up. Thyroglobulin rise during follow-up indicates whether it is residual, recurrent or metastatic disease. 2 to 5 millicuries of radioactive iodine may be used as a diagnostic dose. Then you can stage the disease as per TNM classification. And papillary thyroid cancer, as far as prognosis is concerned, the well-established prognostic factors are age, extrathyroidal invasion, primary tumor size and distant metastasis. And less predictive factors are gender, lymph node metastasis, tumor multicentricity, vascular invasion. PTC in children has aggressive presentation but having good prognosis. As far as FTC is concerned, high-risk tumors are less than 18 years of age or more than 45 years, hard adherent to the larynx or skin. Patient has got symptoms of hoarseness and dyspnea, and the fastly growing one. In iodine areas of deficiency, and in ultrasound, if it is more than 4 centimeter, and male are having high risk factors. As far as the treatment of primary tumors in well-differentiated thyroid cancer, it is always, I used to teach the postgraduates total thyroidectomy, and total thyroidectomy. Of course, there were reservations yesterday, the role of lobectomy and hemithyroidectomy. But I used to teach them as total thyroidectomy is the treatment of choice for all preoperatively diagnosed well-differentiated thyroid cancer. The reason being I got 6 valid reasons like multicentric origin, intrathyroidal lymphatic spread and all. But number 4 and 5, it facilitates the radioactive iodine postoperatively diagnose the metastatic disease and allows the thyroglobulin assay which will be used for follow-up. These 2 points I tell them as priority for why you should go for total thyroidectomy for a malignant nodule confined to one lobe. As far as the management of neck nodes is concerned, for N0 status, total thyroidectomy with paratracheal dissection, whatever available fiber fatty tissue and lymph nodes on either side of the trachea, I used to clear them in N0 status. Whereas in N1 status, so the central lymph nodes go for central neck dissection, and for lateral nodes, functional neck dissection. If you got bilateral neck nodes, go for bilateral MRND. As you all know, the central neck dissection from hyoid bone to suprasternal notch, and on either side the carotid vessels. In MRND, superiorly the lower border of mandible, anterior border of trapezius, inferiorly the clavicle, medially midline, clear all lymph nodes and fiber tissue, of course leaving behind 3 vital structures like spinal accessory nerve, sternomastoid muscle and IJV. A word about locally advanced thyroid cancer. Of course, Dr. Pooja is going to deal with that elaborately. They may be presenting with dysphagia, dyspnea, hemoptysis, stridor, and hoarseness with cough with expectorations. The route of spread through direct extension from the primary tumor or from the metastatic node or indirect extension into larynx. Of course, there are some few terminologies I have used. The laminar ablation, saving of the perichondrium of the trachea, involved trachea, you call it as laminar ablation. There are procedures like partial tracheal resection and circumferential resection. Coming to the involvement of esophagus and rectal angina, many a time the mucosa of the esophagus will be a tough barrier to have the spread. So involved fibers can be resected if it is involved as far as esophagus is concerned. Recurrent nerve, if the nerve is not involved preoperatively and you got some bit of metastatic tissue or malignant tissue in and around the recurrent nerve, I used to preserve the nerve rather than clearing the malignant tissue and removing the uninvolved the nerve which is not causing vocal cord palsy. I won't remove the residual metastatic tissues can be ablated with radioactive iodine in the postoperative period. Once it is involved preoperatively, you can very well sacrifice the nerve. Then coming to the postoperative treatment, postoperatively you can divide the tumor into 3 categories: low risk, intermediate risk and high risk. In all low risk patients, you can subject the patient for suppressed dose of Veltroxin. Whereas for intermediate and high risk patients, I will wait for 4 weeks and do a whole body scanning to find out any residual or metastatic disease. If the uptake in their bed is more than 8%, I will take it as uncured. If it is less than 8%, I take them as cured and start them on suppressed dose of Veltroxin. Those patients having an uptake of more than 8%, where there is a residual disease, I will assess the residual disease with the CT and all and treat them whether if it is resectable, re-resection, or I will go for again ablative dose of radioactive iodine. Then after finishing all of this, you can proceed with suppressed dose of Veltroxin. The role of suppressive dose of Veltroxin, the growth of the tumor cells is controlled by TSH. So by inhibiting the TSH secretion with levothyroxine will decrease the recurrence and improves the survival rates. So the level of TSH, you must keep 0.5 to 2 microunits in low risk cases, 0.1 to 0.5 in intermediate cases, and less than 0.1 international units in high risk cases. So how do you follow up these patients? You do a clinical examination and do a thyroglobulin assay, normal value being 2 to 5 units, and if it is more than that, look for any metastatic disease, whole body scanning, and treatment of local and differentiate. Thyroglobulin assay, when the patient is on a suppressive dose of Veltroxin, you measure the amount of thyroglobulin. If it is raised, take it as a marker that it is getting raised, and you subject the patient for radioactive iodine to localize the disease. If it is not elevated and it is normal, that is unstimulated level. To find out the stimulated level, you stop the Veltroxin for 4 weeks, or if it is T3 for 3 weeks, or you can give recombinant TSH for 2 consecutive days, and you can assay the thyroglobulin. That is called stimulated level. Again, if it is going up, you do a whole body scanning to assess the metastatic disease. So the whole body scan is done periodically in well-differentiated thyroid cancer to assess the residual, recurrent, or metastatic disease. A diagnostic dose being 2 to 5 microunits. Patient should be hypothyroid, that is more important before doing whole body scanning. After surgery, to achieve, as I said earlier, you must stop Veltroxin. The patient must be in hypothyroid state. A few words about the metastatic diseases in well-differentiated thyroid cancer. If there are lung secondaries, these are more common in young patients with papillary carcinoma. Lung is the only site in children, and the pattern of involvement may be micronodular to diffuse variety. The diffuse infiltrates are detected by CT scan. If it is solitary metastasis, you can go for a section. If they are multiple, you can ablate the disease with radioactive iodine. Of course, the total dose of radioactive iodine ablative therapy should not go beyond 600 microunits because of the fear of pulmonary fibrosis. As far as bone secondaries, they are more common in older people with follicular carcinoma. They may be presenting with pain, swelling, sometimes pathological fracture. The osteolytic lesions are very difficult to detect in X-ray. Can go for CT or MRI, which will be better to pick up the bony secondaries. If possible, you can go for resection. Again, radioactive iodine ablation, sometimes external beam radiotherapy along with bisphosphonates. If there are brain secondaries, you can go for solitary metastasis with neurosurgical resection or radioactive iodine ablation with external beam radiotherapy along with anti-edema measures. If you are not able to make out or localize the metastasis, empirically you can give a dose of radioactive iodine ablation therapy. A word about reoperative thyroid surgery. Sometimes patient may have, will present you with history of hemithyroidectomy, and the biopsy report as follicular or papillary carcinoma, you are planning for completion thyroidectomy. So the removal of contralateral lobe along with the isthmus and the pyramidal lobe after initial thyroidectomy or lobectomy, you must collect all the data, the discharge summary, everything, every history should be collected prior to your plan. The vocal cord examination is mandatory, whether they have the normal or previously during surgery any injury to the vocal cord and all, that has to be done. And ultrasound radioactive iodine to assess the remnant of thyroid. It is always better to go with lateral approach, the virgin area, wherein the dissection is in the plane of between the sternocleidomastoid and the strap muscles. Identification of recurrent nerve at the point of entry, which is medial to the lateral dissection. So, dear friends, to conclude, 90% of thyroid cancers are all well-differentiated type. Total thyroidectomy is the treatment of choice, even if it is confined to one lobe. And central neck dissection, functional neck dissection are the options for management of nodal involvement. Post-operative treatment include radioactive iodine scanning, thyroglobulin assay, and treatment with either ablative dose of radioactive iodine, suppressed dose of Veltroxin, and sometimes an external beam radiation. So follow the patient with clinical exam, thyroglobulin assay, and whole body scan. Thank you for the patient hearing. Thank you.
Thank you, Dr. Marathu Pandian, for covering differentiated thyroid carcinoma. Any comments or questions from the floor? I think the role of radioactive iodine in low risk is coming down, and previously the cutoff was 1 centimeter. The primary lesion is 1 centimeter or less, we don't give. Now, of course, they take other criteria on histology to decide whether we need radioactive. Previously, it was routine to ablate all of them, and now the role of even the need to radioactive iodine is being challenged, and there are different studies going on to see what is the optimal size and criteria to give radioablation. Any other comments? Or?
Good morning, sir. I'm a radiation oncologist. So we don't routinely see these patients now in our clinic, but just had a question. When will you actually go for a stimulated thyroglobulin? When will you do that? What is the indication? When will you suspect and do the stimulated test?
So when will you go for assessing the stimulated thyroglobulin assay?
Yes, sir. Yes, sir.
So once it is normal, the unstimulated level is normal, and you are suspecting some metastatic disease. Suppose patient has got bony pain and then tenderness in this bone and all. Clinically, you are suspecting metastasis. I'll go for assessing the stimulated level.
Oh, thank you, sir.
There are no more questions or comments. Thank you, Dr. Marathu Pandian.
Thank you, sir.
Thank you, sir, for that talk. Now for the next endocrine lecture, may I invite Dr. Anjali Mishra for her talk on parathyroid incidentaloma, diagnosis and management. Ma'am, please.
Yeah. Good morning, all. And I thank the organizers for having me here and congratulate them for conduction of this very successful conference. And I had been given a very interesting topic. I was asked to speak on parathyroid incidentaloma. So I would say that I am still curious about this entity and trying to learn about this myself, and I hope I would have some comments from the floor to enrich my knowledge as well. So I'll just present a case. This case I operated last week only. She was a 57-year-old lady who presented with Graves' disease, and during evaluation with ultrasound, she had a diffuse kind of goiter with no suspicious thyroid nodule. Her thyroid scan was also done, which showed diffuse uptake, but iodine uptake was not up to the mark, and it was decided to take her up for surgery. So we perform a total thyroidectomy, and during surgery, as you can see, we could find that right inferior para was enlarged, and it weighed approximately 500 milligram, and largest diameter was more than 1.5 centimeter. So during surgery, while we noticed this gland, we took a PTH sample, and which was high, approximately 3 times of our upper reference range. And after completion of surgery, this was not classic excision like 5 minutes after surgery, but once we closed down the patient, we took another sample, and that showed that parathyroid levels have come down to normal. So what would you call it? So going by definition, this is parathyroid incidentaloma. But suppose this patient was showing a suspicious nodule on pre-op ultrasonography, would you still call it parathyroid incidentaloma? Any thought?
It was a bit of surprise because this lesion size is very significant, like 1.5 centimeter. It's very unlikely to missed on ultrasound. So first of all, because the ultrasound features are very important to decide whether it is something, because in this picture, it looks like an exophytic nodule from the thyroid only, maybe because it is, the specimen is placed too close. But like ultrasound features make a lot of difference what exactly is, whether it is really an incidentaloma or it's a part of thyroid.
Okay. So I'm just saying that it was detected as a parathyroid nodule on pre-operative ultrasound. So whether you would say it is incidentaloma, yes or no, I would say the answer could be yes as well as no. Yes, if this thing probably patient is normocalcemic, because once you suspect a parathyroid incidentaloma, being an endocrine surgeon, your obvious choice, and in fact in some institution it is routine to measure serum calcium before going ahead with total thyroidectomy. So if it is high, you would say, then you would start working on the line of PHPT. Then we do not know whether this is asymptomatic PHPT or would is still classify for parathyroid incidentaloma. So the crux of matter is this only. So what is background? So if we, why did I presented this case before my talk? If we look at incidentaloma, what is the dictionary definition of incidentaloma? It is an abnormal lesion or tumor detected by chance during a medical imaging test, physical examination, or surgery. And we know with increasing deployment of sophisticated cross-sectional imaging, the incidence is rising. But if we look at parathyroid incidentaloma, most of these incidentaloma, at least historically, were not diagnosed on preoperative imaging. These were picked up during surgery. So that makes a big difference. However, this thing, once I have said this thing, with increasing use of sophisticated and high-frequency ultrasound, we are picking some of these lesions in preoperative setting as well. So if I have done some search, and I did not find many articles on this topic. So obviously, this is still a kind of evolving entity. So, however, there is a lot of literature, and if we look at autopsy incidences, as is true for any incidentaloma, incidence on autopsy in autopsy series is quite high, and it is to the tune of 2 to 7.5%. When we look during thyroidectomy, the incidence is between 0.2 to 4.5%, and usually in most of the series it is less than 2%. But a very interesting thing is, if parathyroid incidentaloma do exist, we would encounter definitely some of those during parathyroidectomy as well. And I'm sure this thing, all of us have encountered many enlarged parathyroid during parathyroidectomy, and we take it out, but despite that, intraoperative PTH does not fall. So it is quite possible that there are some existent, and in fact, some CDs have commented on this entity, that there could be non-functional gland found during parathyroidectomy. And as is true for any parathyroid disease, these incidentaloma are commoner in women as compared to men, and people having history of radiation are more likely to develop these. And as is true for overt disease, these could be uniglandular affliction, or there could be multiglandular incidentalomas as well. And so far as functionality is concerned, so then it becomes a tricky issue. If it is functional, it is not incidentaloma. But if you find any abnormal lesion, and whatever series I have gone through, the incidence of functionality turned out to be to the tune of 30 to 40%. So let's look at some large series. So this is one series where during thyroid ultrasound of 266 patients, they picked up 32 incidentaloma. Out of these, 37.5% were functional. And Sudhi was saying that ultrasound does make any difference, but so far as functional and non-functional tumors were concerned, there was no difference in reference to size, location, echogenicity, or vascularity of these lesions. Only correlation which they found, and that could be just fortuitous, was that when they took out multinodular glands, whether it could be multilateral or macronodular autoimmune thyroiditis, then chances of functionality was more. So, but as I said, that could be just fortuitous, and there is no pathophysiological basis of this finding. So this is another series which had looked into the diagnostic accuracy of ultrasound vis-a-vis ultrasound-guided FNA for estimation of PTH or just pathological examination. So in this last series of more than 6,000 patients, there were 112 suspected cases of parathyroid on ultrasonography. Out of these, only 24 turned out to be parathyroid incidentaloma at the end of day. And out of these, 14 could be diagnosed based on pathology, and rest 10 were diagnosed on FNA PTH estimation. So incidence in that series was 0.4%. So just look at this feature. So in this, in contrast to what Sudhi was saying, positive predictive value of ultrasonography in diagnosing these parathyroid incidentaloma was only 21.4%. And if we compare FNAC with FNA PTH, as was expected, sensitivity and in all other references, specificity, accuracy, positive predictive value, and negative predictive value, FNA PTH fared superior to FNAC alone. And interestingly, after surgery, 4 of these patients became symptomatic, not before surgery. It's quite possible that we were looking at a multiglandular disease in this scenario. So, but basic question whenever we encountered these lesions is to ask whether they do represent early stages of overt disease, because that affects our management and evaluation strategy. So for this, I have selected this series by Helman et al., and they have done a quite extensive investigation into this issue. So in this series of, sorry for my throat, 594 patients, the incidence of parathyroid incidentaloma was 1.5. They detected 9 patients, and these 9 patients were having 11 enlarged glands, and weight of these glands varied between 110 to 1,000 milligram. And all of these patients were normocalcemic. And however, when they look for PTH and alkaline phosphate estimation, only one patient has increased values. And mind it, if they detected it during surgery, the sample would be collected at that point of time, and there could be false interpretation, and there could be problem during collection of specimen as well. And interestingly, when they subjected these patients to routine histology, they could find abnormality only in 8 out of 11 enlarged gland, and they confirmed it with staining for cytoplasmic fat, and we know that is done with oil-red staining. Okay, I missed that. But when they looked for this thing, more microscopic level, they found that all but one had decreased calcium sensing receptor, and they did confirm it with immunohistochemistry analysis. And and calcium regulated cytoplasmic concentration was abnormal except in all patients except for one. So meaning thereby all of them had some earlier changes related to early PHPT. So they concluded that these findings underline that obviously there was diagnostic difficulty if you look at through routine microscope, but there were some inherent changes associated with early PHPT cases. But we do not know. Obviously, they could have not speculated whether these are likely to convert into overt PHPT in future. So keeping in the background all these information, the question is, if we encounter these during our practice, how are we going to evaluate these or manage these? So far as evidence is concerned, there is only retrospective data. We do not know natural history of this entity. We can only speculate. But it would be, maybe, I'm not certain, but we can say that these could be associated with some non-specific parathyroid-related symptom. Because even this thing in today's era, when we are operating on only biochemical proven PHPT on deep poking. Majority of these patients are having symptoms which are not classically associated with PHPT. And obviously their gland seems less functional, so many of these would be having normocalcemic PHPT or a normal PTH PHPT, and we do not know in this thing future we would be having an entity of primary hyperparathyroidism where both calcium and PTH are normal, and we would have some other modality to diagnose these cases. So what would you do? So obviously, if you suspect or pick up any suspicious lesion on preoperative ultrasound during evaluation for thyroid disease or for that matter, any other neck disorder, you would definitely go ahead with serum calcium and PTH. And just now, as I said, many of these would be having a normocalcemic PHPT or other way around. If possible, this thing, ultrasound-guided FNAC for PTH determination would be a better bet in the situation where all the biochemical investigations are normal. May or may not be helpful in this scenario, which are already picked up on ultrasound. And if everything is normal and we encounter these tests like we encountered during this thing, our experience, as I showed, is as representative case, then intraoperative sample could be taken for calcium and PTH estimation. But here, mind you, that PTH may be erroneously high, because we have seen that after manipulation, when we are performing parathyroidectomy, the baseline PTH taken at that point is much higher than what we have taken in preoperative scenario. And we can always confirm any removed gland with frozen section, whether it is parathyroid tissue or not. Though regarding adenoma and hyperplasia, we have to wait for definitive histology. And if everything is normal, in order to prove that these are having early stage of PHPT development, we could subject them to for calcium sensing receptors as well. So the question is how to deal these patients in practical scenario, whether we should excise them or not to excise them if we encounter these during surgery. So the basic basis for deciding this would be tilted in favor, I would say, excision, because the question would be whether we would be dealing with increased incidence of hypocalcemia, or we are looking at the scenario where in future these will become overt, then we have to again go in and excise them at a later date. So question remains between hypocalcemia versus redo, and as a surgeon, I'm sure most of us would like to take these glands out, particularly if only one gland is involved. If more than one is, then that is a different case altogether. So in order to substantiate this theory, I have taken out this study where they have looked into 124 PHPT subjects. Out of these, 22 were detected as parathyroid incidentaloma, and they found that, during follow-up, their calcium levels were lower and they were less likely to have any PHPT-related complications. However, interestingly, in their series, these patients which were detected on preoperative ultrasound, the MIB positivity was also high. And this statement, they have also concluded that frequency of surgical management didn't differ between this group, but that was because of selection bias. However, it is very important to note that as we will detect more of these on imaging, so probably we would be going in more aggressively for surgery, as is true for any kind of incidentaloma. Like for adrenal incidentaloma also, there are some set guidelines, if it is non-functional less than 4 centimeters, don't touch it. But once an incidentaloma is detected, it is very difficult to convince the patient, and surgeon or physician for their own reasons would like to intervene surgically more often than is required. So whether that is really beneficial in long term or not, only time will tell. So in conclusion, I would say that obviously there is not much data and it is kind of evolving story, but burden is definitely likely to increase in future, and management could be decided on case-to-case basis whether we have picked up it in pre-op setting and whether that patient is undergoing surgery for some reason or not. And if it is picked up during surgery itself or thyroidectomy, probably the balance would tilt towards removal. So, and that is end of my talk, and I would be very happy to invite comments from the floor. Thank you so much, and thank you so much.
Thank you, Anjali, for dealing with a very tricky topic, I think. But I think all of us during our practice and operation, we have seen so many times the parathyroid gland is enlarged, and always the dilemma is whether to. So what I'd probably do is I look for the other parathyroids carefully, and if I find that this is the only one, I send for frozen, make sure, and then only I take it off.
Yeah.
The other thing I was thinking scientifically, is there anything related to TSH receptor which has got a stimulating effect on the parathyroid secretion, and whether that stimulates the gland to enlarge, especially in thyrotoxicosis, whether there is some autoimmune mechanism? Because we have also seen in Graves' disease that we sometimes the one parathyroid gland is more enlarged during surgery only, and of course we always do a calcium, and usually calcium is within the normal range whenever we have found this abnormal parathyroid gland.
Yes, sir. Actually, that is this thing. I would also concur with you. Whatever incidentaloma I have found, barring one case, mostly those cases were having either Graves, mostly Graves or toxic goiter. So that could be, I thought, because of the inherent pathophysiology which lead to kind of subclinical hungry bone syndrome and enlargement of one or more. But interestingly, only one was enlarged. It was never that all the glands were this thing enlarged. So that is quite an stimulating thought.
Very nice
Paul,
talk.
Deepak, any ideas on somebody else?
Yeah. Very nice talk, ma'am. Fortunately, I've encountered these like 3 cases in the last 2 years, and all of them were detected pre-operatively because I routinely do calcium for all patients, whatever I take for surgery. So I think this is a small test which can be done by all of us, and it's easy to detect these patients pre-operatively, and then even maybe has shown a concordant finding with them. So I think that's a good test. I mean, calcium, this is what happens even in Western countries. They do routinely calcium. We do not do that so often. So I think I just
that's what I'm saying. Yeah. When we do calcium and if it is raised, then it is no longer a parathyroid incidentaloma. The question is when we are detecting it on parathyroid, and as a parathyroid surgeon also we know when calcium is raised in 20 to 30% patient, imaging will not pick up anything. But it's the other way around. When you are seeing enlarged gland, whether it is functional or not functional, or whether it is an early stage of overt disease.
I got your point, but the point is, suppose we do not do this calcium pre-operatively and we take the patient, then what? Then also you're going to find an enlarged gland, but you do not have the values of calcium. So
but
that
I
is
think
what I wanted to
we do, I don't know about others.
No,
I always
routinely do
thyroid calcium for all patients who go for surgery with total thyroidectomy.
We routinely do, but some centers don't do it. Don't. Yeah. Yeah.
So that's also the second issue is also about cystic parathyroid. Sometimes that can be. We've had detected an inferior parathyroid below the thymus, which was not picked up on ultrasound intraoperatively, and you get this clear cystic fluid, and that's like a true parathyroid cyst. That also can be a incidentaloma situation. Thank you.
Thank you.
I have a question, sir. So if the calcium is normal preoperatively and you've planned a total thyroidectomy and you find an enlarged gland, like sir said, you send a frozen, and the frozen comes back normal, then do we still take it out?
Doesn't matter. Because whatever abnormality we have detected that has been taken care of, it didn't turn out to be parathyroid. But the question is if it is parathyroid, so are we this thing, how intensive we should follow up these patients? Because that could be early stage of multiglandular disease as well. So we do not know.
Thank you.
Yeah.
Ma'am, great talk actually. And for the benefit of, like Dr. Smita told, like the recent paper or review on parathyroid incidentaloma classifies parathyroid incidentaloma into RPI, SPI, and PPI. So RPI is radiologically detected parathyroid incidentalomas, where you do not particularly image parathyroid, you find some nodularity, and as ma'am rightly pointed out, calcium is normal. Surgeon detected during intraoperatively, not doing a parathyroid surgery, and sometimes somebody does a hemithyroidectomy, and the pathologist says it's not a thyroid nodule, it's a intrathyroidal parathyroid adenoma, or like Paul has said, like a cyst, which is mistakenly removed. So these three entities, and as madam rightly pointed out, there is lack of literature about these parathyroid incidentallomas, but because of the wide availability of imaging, we are now seeing a lot of parathyroid incidentallomas. Thank you.
Okay.
There are no more comments. Thank you, Anjali.
Thank you, sir. Thank you.
Thank you, ma'am, for that very informative and interactive session. Now for the next session, may I call upon Dr. Pooja Ramakant to present on the topic, Management of Locally Advanced Thyroid Cancer. Over to you, ma'am.
Thank you, and very good morning to all of you. Thank the organizing team, very well organized. I'm still dancing in my dreams. So I'm going to talk about a very ugly cancer, very difficult disease for the patient, difficult for surgeons to manage, both of us. The issues with this locally advanced thyroid cancer entity is they are invaded to structures, like in this patient to skin or straps, larynx, trachea, pharynx, esophagus, or they can invade even the major vessels in the form of thrombus in the IJV, or to the subclavian vessels, or they can encase the carotid vessels. And the skin, when sometimes they ulcerate, they get involved, then we can't really save the skin and we have to sacrifice it. And then we need some flaps or skin covers to close. So before beginning with the management part, I'll just share that the recent changes which have happened in the management classification, that if you see earlier, it was considered in stage 4A, this locally advanced thyroid cancers. But people realize that with management or aggressive surgical management, especially and adjuvant therapies, the prognosis, the survival rate has improved, and now they have been shifted in stage 3. So if you see, even locally advanced, they have classified, if it is involving anteriorly, it has gone in stage 3. And if like larynx, trachea, esophagus, RLN, whatever structures anterior to thyroid is involved, if they get involved posteriorly to the prevertebral fascia encasing the major vessels, then the prognosis is worse, and they are called very locally advanced, and they are categorized in stage 4A. So instead of 4B, they have gone in 4A, and 4A has been upstaged to stage 3. So it means if we really put efforts in doing aggressive surgery in this subgroup, patient benefits from that. The imaging modalities, apart from ultrasound, definitely include CT scan. You may need an MRI for soft tissue structures. And if trachea is involved, you may do endobronchial ultrasound to characterize whether the rings are involved or not, or what is the classification. So coming to the roles of various therapeutic modalities, radical surgery definitely has a role in these patients. TKIs, tyrosine kinase inhibitors, have a role. Like neoadjuvant setting, you can downstage if you think it is not operable, or you may use in the adjuvant setting. Radiation therapy has a role in ulcerated, bleeding, fungating thyroid cancers just for the hemostatic purpose sometimes, or to palliate the pain or in adjuvant settings if the margins are closed. Chemotherapy has a very dismal role, not a great response to these patients. However, it is there. TKIs have been recently, most of us are using it. Lenvatinib or sorafenib in DTCs, vandatinib and cabozantinib have been recommended for MTCs. They have a role in RAI refractory thyroid cancers, but a lot of patients have side effects like fistula, they bleed, cardiovascular issues, hepatic disease, although recently we have a patient in ward who has got a esophageal fistula because of the TKIs. So we are managing that fistula, and it's difficult. That patient has been there since last 3 weeks, doing a lot of extra workup, barium meal, barium swallow, and all the things to confirm that fistula. Then management is difficult. Stopping the TKIs, the disease progresses. He's inoperable. So a lot of issues crop up. So they are not easy agents to use it. However, if you see in studies, in trials, the response rate has been great. It is up to 65% in 2 years versus 2% response rate in the placebo group in 3 months, sort of a thing. So it has a definite benefit. However, a lot of patients, and more than 50% of patients, they have faced side effects like hypertension, diarrhea, fatigue, decreased appetite, other things. So coming to the aggressive surgery, if trachea is involved, definitely we need to do the resection. Now we have to decide whether we do the safe resection or we go for window resection or circumferential resection and anastomosis, or partial or total laryngectomy has to be added. So for that, we need to know the extent of the involvement, and we can resect maximum 11 rings, and we should be 1 ring above and 1 ring below the extent of involvement to have negative margins. So in Shin's classification, in stage 1 or 2, we can go ahead with the shave procedure. But once the cartilage gets involved, then we have to do either window resection or resect circumferentially and do end-to-end anastomosis. The benefit of doing aggressive surgery is, if you see, if you have done a complete resection, the 3 years, 5 years, 10-year survival rate is in the range of 87% or 78%, quite good. But if you have done an incomplete resection, it falls down to 64%, 43 or 24%. So you see there is a benefit if we do an R0 resection in this subgroup. Now coming, this aggressive surgery definitely has better results compared to conservative surgery. If we do a small shave resection and give adjuvant radiation therapy, that has shown that these patients have less survival compared to if we have gone ahead and did a laryngotracheal resection with R0 margins. So definitely radical surgery has a better role. If we have done end-to-end anastomosis post-resection, so in the trachea we can do in CMC Vellore. When I was there, we had done many patients, and we found the trachea heals quite well. Not major morbidities happen. We can extubate the patients on table. They do well. And even in the long-term follow-up, patients had come back with a good quality of life, and they were doing well. So it's worth doing it. This is CMC Vellore's publication of Siddharth on the laryngotracheal resections in these patients of 22 series. Anybody who wants to read, please go ahead and see. Then we can involve with the ENT surgeons and go ahead and resect the larynx also. If it is involved, it's good to do these things, but if we think it's not, we can't do it, patient is inoperable due to varied reasons, we may use laser therapies and coagulate or microwave ablations or put a stent if it is metastatic and totally inoperable. If RNN is involved, just the superficial fibers are involved, we may shave it off, but if we think the nerve is grossly involved, then we may do the resection anastomosis, or we can take a nerve graft from the ENSA or some other nerves and put it. But we need to use very fine sutures, 8-0, 10-0, so we need really loops to do it. If major vessel thrombus is there, then we can't use TKIs, that's a contraindication, or radiation therapy. Then surgery again has to be the only therapeutic role is there. We can resect one IJV, but if both IJVs are involved, then either we do the reconstruction of one of the IJVs, or we do a stage surgery after 3 months, so let the collaterals be developed, and then we may be able to remove both sides. And better to use scissors or scalpel, sharp dissection to strip off the subadventitious layers from the carotid. So if you see if carotid is encased or involved, that is also resectable, and we can do it by doing just sharp dissections. So if most of the cancers, the good thing is thrombus doesn't get stuck to the wall. So we can just open the wall by having the control upper and lower ends, and we can do a thrombectomy and get away with it. Very rarely it may involve the wall, and then we have to sacrifice part of the vein, and we may need some extensive resection or replacement, and we may need the help of a cardiothoracic or vascular surgeon. This is our own patient in Lucknow in KGMU, where we had did a thrombectomy and sternotomy, and then this patient did well for 4-5 years. This is a study from Sabaz who had published when he was in CMC Vellore. There was a patient who had carotid artery encasement, and we could do a subadventitial layer resection, and we could get away with this. So this patient also did well. So coming to the TKIs, and I could find in my own department in KGMU that we are giving TKIs to, I think, more than 10 or 15 patients have been receiving for last 1 year. And recently they came so I could get their data. So it's just the scenarios. When this 51 years postmenopausal lady, she had the thyroid nodule for 10 years duration with rapid increase in the last 3 years. She was diabetic, and true-cut biopsy was done to rule out anaplastic, and this was Hürthle cell neoplasm. And in 21, when she came, she was sort of inoperable with a large goiter, lot of lymph nodes and invasion, locally advanced thyroid cancers. She refused surgery. She was offered, but she didn't agree for it. Then she was put on lenvatinib, and this, after 1 year, if you see, from 7.5 centimeters, it has slightly reduced, but it's just 5 to 10% reduction in 1 year duration. However, she is still continuing the TKI, and she's still managing on it, and she doesn't want surgery. So this was the first picture when she came with the skin involvement, and all the skin was involved and ulcerated. However, the ulcers have healed, and she is happy with whatever reduction she has, and even now she is not agreeing for surgery. This is another lady, 65 years, who had a goiter for 15 years with rapid increase in 3 months in the form of dysphagia, voice change, and breathing issues. She was also started on TKIs, and she just came a few days back, and there was sort of 40% reduction, I can say. She was initially given sorafenib. She took for 5 months, but there was no response, and then she was changed to cabozantinib. Then she had a response of 30-40%. However, she had hand-foot syndrome because of that. And if you see her CT scan in September 21, this was here, the carotid was encased, sort of inoperable. Then in April 22, again CT was done, which was on when she was on sorafenib. Slightly she had progressed, and then she was put on cabozantinib. In July, it had reduced, and she was also quite happy, and it became mobile also. Just 2 days before when I was coming, we had repeated the CT scan, and it had become sort of cystic. You see, still the carotid is encased, but I think she's just at window period when it has shrunken, and we may be able to take it off. So we are discussing with the cardiothoracic surgeon, because the brachiocephalic vein is also involved in this, so she will be needing a sternotomy. So now at this point, we can't be scared of the issues related with aggressive surgeries, and because if we don't right now operate her, she may become resistant and she may progress, and then we will lose that window period of offering her the surgery. And she has been taking for more than 1 year. So how long to give cabozantinib or something, that is also an issue. So these are difficult tumors, very difficult to manage. Surgeries are difficult, TKIs are difficult to give. So we need a multidisciplinary team meeting to have proper discussions. Many a times we have given radiation therapy, especially like this fungating cancer, where they bleed, so that RT has a good hemostatic effect to help us to manage these patients. And better to have a radical surgery with R0 resections, patients do really well. And if you think that they need adjuvant therapies also in the form of RAI or TKI or RT or chemotherapy, you may continue them, because sometimes they have some recurrences and they are difficult to reoperate. So we have to make the decision based on the patients and the disease scenarios, and I think Taylor made the decision for each patient. So with this, I thank you CMC team. I thank my residents, especially Rizan, who helped me in getting all these photographs periodically, whatever they had saved. So this I'm happy. If anybody has the experience of TKIs and the experiences, how many they have operated, or please share that.
Thank you, Pooja. It's a very difficult area to treat and to discuss also, because these are patients we see who neglect themselves and come in a very advanced stage. And the dilemma is, as surgeons, we always want to operate, but the important thing is we must do a good resection, because wherever I have attempted partial, within a few weeks or months, they come with very aggressive tumor and we lose the patient very fast. But this TKI is a good option in many patients and we have seen good regression. I think Paul, Deepak and all, they have a large series of these patients whom they have treated.
Pooja, thanks for this. Interesting. Were you able to give TKIs to patients who have not got a histopathological diagnosis of malignancy? Like you had a Hurthle cell neoplasm, but clinically it was malignant. And do you give the TKI or medical oncology gives the TKI?
So we consult with them. So, but we give ourselves because medical oncologists have got limited beds, so they can't admit all the patients. These patients get through cancer card, so it is free for them. So it's from the government side. So we admit them, and then we also want to follow up these patients, what's happening. So we try to give ourselves, but in consultation with the medical oncologist.
Okay, so are the patients all have a proven malignancy?
They have proven,
based on
yeah. For getting the cancer card made, we have to prove it's a cancer.
Right.
Then only they get registered in the government.
Sure, yeah, okay, that makes sense. Interestingly, our experience with vandatinib for MTC has led on to surgery.
Okay.
Whereas DTC with lenvatinib, most patients don't come back for surgery. Some, either we are lost to follow-up. In fact, we were also looking at that. So Sean and I were going through data in our department to see. We found 2 or 3 patients who are on lenvatinib, but have not reached or gone back to surgery yet in terms of resection and operate and take out. I don't know, Paul, do you remember any patient post-lenvatinib, neoadjuvant setting and then operate?
Actually, I can recollect 3 patients. So one patient I did operate. One patient had such a fantastic response that that patient didn't want to come back. And third patient somehow expired at home. And yeah, that's all.
Amit sir also wanted.
No, I think I've used in 20 patients, but I'll say it's more for palliation than for making it operable. So for anaplastics and poorly differentiated, it works very well. Patient has a good quality of life, survives for 1.5 to 2 years. Patient who comes in stridor has a fantastic response with the TKI. So I would suggest all should use in anaplastic and poorly differentiated. So giving 2 years of life to a patient who has 15 centimeters poorly differentiated, coming with stridor and living for 2 years is very gratifying. But as Deepak said, for locally advanced differentiated thyroid cancer, I have yet to make a patient bring to the table, Unfortunately, it's a very narrow window that we get, And the moment we decide, I had a patient I was, going to operate, but because of COVID, I couldn't do it. And within 2 months, she progressed, So, but use very carefully, a lot of side effects are there, Diarrhea is a major complaint, weakness, hypothyroidism, hypertension is very important, And don't start TKIs in a patient who's had radiotherapy, external, because there's a risk of fistula and hemorrhage. So these are good drugs, but I don't know when to start, when to stop. It's still very, very difficult. But for palliation, they're fantastic drugs. For poorly differentiated anaplastic, I've stopped giving radiotherapy to anaplastic, stopped giving doxorubicin, just TKIs. They work very well. Thank you.
I think if there's a panel discussion later, but the indication for a TKI would always be for inoperable, progressive, metastatic or disease. But we are using this in a neoadjuvant setting with the intent of getting to theatre. Those 3 patients, yeah.
I remember one case now where we put on sorafenib, and she came down and we offered her surgery. She needed a flap actually, and she got it done elsewhere, and then she recovered under the flap. But now with the TKA, it's under control for more than a year with the flap recurrence. So she's still, we are still observing to see what happens, whether we can go in again. So I think, yes, it's a very difficult balance. And
His radioiodine scan and ablation, they keep on shifting. And ultimately, when he got it, by the time he had developed pulmonary metastasis. So that was the sad part of it. We could take it out, but I don't know. So we are planning to again put that patient on.
I had one submission from Roma, I think, in World Journal of Endocrine Surgery. You operated that patient, I believe. I think I sent it to somebody for review as well.
So this was a case of follicular thyroid CA. So he was operated some 20 years back. Subtotal was nodulectomy was done. Then he had a fungating mass over the anterior neck. So initially I thought, let's start lenvatinib. And he had a great response, so I was able to operate properly. And now he's planned for radioactive iodine. I just wanted to ask you, ma'am, you said, mentioned about the dose of lenvatinib, 24 mg. None of my patients can tolerate more than 14 mg. I mean, I just tell them that whatever dose you can take, just try that. And even in some anaplastic, one lady is taking just 4 mg drug and still she is able to survive like 5 months. She has still crossed 5 months in anaplastic CA. So I think lenvatinib is a great drug.
They are able to tolerate it, and because they get free, so they always come, so they don't lose the follow-ups.
Yeah. For us, that is not there. It's not free. But I'll tell you one thing, patients become very smart. They know when to taper the dose, stop the dose, and restart it. That also they learn.
I think it will be a good idea to pool our early experience and publish it, even if Indian General Surgery, whatever, you know. So at least an early experience from 3-4 centers will really, it will be a good for people to follow it and, in practice. Because palliation is fantastic with this.
Yes.
I think when numbers are small, it's very good idea to pool. And
exactly.
share this thing experience. It may come as it will be like a good thing for others to follow.
This Dr. Kamal is there from AIMS. What is your experience? Are you giving TKIs?
Basically adjuvant setting only.
Okay, not in neoadjuvant or palliative?
No, we haven't tried in, most of the patients in whom we are giving, they are not coming back. Medical oncology people, they are...
If the medical oncologist gives, you lose the patient, so it's good that surgeons give themselves.
We won't learn about the side effects and how much patient is tolerated. So we have to generate our own experience, learn from our own patients. So that for the next patient we are wiser.
Once we will start giving only, then we can also...
So what I do is I sit down half an hour with my patient and try to learn each and every side effect that he is undergoing. Because only then I will understand
remember
the next patient and whatever complaints the patient gives. So we have to learn from our own patients. That's very important.
That's true. Thank you.
Thank you.
Thank you, Naisa, for chairing the session, and thank you, ma'am, for a very interactive session. Now, without wasting any more time, can we move to the next session? May I invite Dr. Amit Agarwal to present his plenary lecture on state-of-art management of medullary thyroid cancer.
A very good morning to all of you. At the outset, I'm thankful to the organizers, Paul, Deepak, Sean, and the President and Secretary of the Association. It's wonderful to be back in CMC as always. So my task is to share with you some of the recent advances, and we have to think beyond surgery in medullary thyroid cancer. I'm aware that as surgeons, as endocrine surgeons, we see not more than 5 to 10 cases in a year. So the experience with each of us is rather modest. So bring greetings from SGPGI. They constitute a very small proportion of all thyroid cancers, just 5 to 10%. But for the postgraduate, it's important to remember how is it different from a differentiated thyroid cancer. Remember, age is not a prognostic factor in medullary thyroid cancer, unlike the DTCs. The prognosis is intermediate between DTC and ATC. The clinical course is heterogeneous. You have a very indolent medullary thyroid cancer and you have a very, very aggressive medullary thyroid cancer. It has a very high rate of nodal metastasis to both central as well as lateral compartments. And approximately 1/3 of these tumors could be familial. Initially it was like 5 to 10%, but I'm sure you would agree that now most of us see at least 30% of these being familial. They do not concentrate radioactive iodine, so you cannot use radioactive iodine as your adjuvant therapy for this. And similarly, the TSS suppressive therapy does not work. So these are the seminal differences from the differentiated thyroid cancer. The clinical presentation, as most of us know, the patients may present with a solitary thyroid nodule or a multinodular goiter with and without lymph nodes. But as I said, lymph node involvement is very high. But quite often they present with compressive symptoms of hoarseness, dysphagia, and dyspnea. Diarrhea is a very important symptom, and if they have metastatic disease, they can present with flushing as well. And so for postgraduates, always remember to take a history of diarrhea in a patient with solitary thyroid nodule. And even 1/3 of your patients might have diarrhea, So this is a patient who presented with a solitary thyroid nodule. Other patient presented with a huge goiter, compressive symptoms. It was not anaplastic, it was medullary thyroid cancer. And this patient presented with, a positive Pemberton's. You can see the flushing on the face and the neck. Now, how to approach when you suspect a medullary thyroid cancer? You make a diagnosis with your cytology or with serum calcitonin. It's important to stage the tumor because these metastasize quite early, and so use specific imaging to stage the tumor. And of course, a very important part of your workup is to do genetic studies to rule out inheritable syndromes like MEN2A and 2B or MEN3 as they call FMTC. So the only advancement that has taken place, we always have been dependent on cytology, but cytology could be inconclusive in 20 to 30% of cases. And now they have used these Afirma genomic sequencing techniques even for MTC. We have been talking and hearing about Afirma use in DTC, but now they are also using in MTC so that you have a good preoperative diagnosis and not just depend on the usual cytology. Serum calcitonin is a very, very sensitive marker, very high sensitivity and specificity. But remember that there are certain situations where you have a false elevation of serum calcitonin, especially lung and prostate tumors and pheochromocytomas and paragangliomas. Patient having CRF, the calcitonin may be spuriously raised. Hyperpara patient may have a high calcitonin level. And remember, autoimmune thyroiditis is a very important cause for false elevation of calcitonin. So in your practice, be careful and remember these situations. Some centers like to do washout fluid, for calcitonin estimation. It's also a very sensitive test. Carcinoembryonic antigen is usually used as a prognostic indicator, but you can use it to identify a subset of patients who are likely to be more aggressive. Now remember, this is a heterogeneous disease, and so your take is to identify those subset of patients who are going to behave aggressively. And CEA is one marker, not only as a prognostication, but use it to identify a subset of patients so you can do a proper counseling and aggressively treat this subset of patients. So as I mentioned, imaging, the first and the foremost imaging is a CT scan of the neck and the mediastinum. And you can do a HRCT as well to rule out mediastinal lymph nodes and lung metastasis. Coming to the treatment, remember MTC is a surgeon's disease. It's very important to remember that. You don't have adjuvant therapy, radioiodine doesn't work, TSS suppression doesn't work. So it's an aggressive disease. And survival correlates with stage. Again, not to overemphasize, C cells do not concentrate radioiodine. A good thing for surgeons is that the spread to lymph nodes is very, very orderly. Keep that in mind. It spreads to ipsilateral central compartment, then contralateral central compartment, ipsilateral lateral neck, and then the contralateral, and then to level 7, and so on. Again, to remember, chemotherapy, radiotherapy doesn't work. So it's a surgeon's disease, and the first surgery is the best surgery. Now, again, to emphasize, age is not taken into account unlike a DTC, and survival is related to your stage. So you see if it's stage 1, the survival is almost 100% and it drops down to 20% in stage 4. So staging is very important. That is why I emphasized you should do a preoperative staging workup. Now this is a very interesting slide and I think you can use it in your practice. It's always a dilemma as to what should be the extent of surgery. Should you dissect the contralateral lateral compartment? Should you not in a case of medullary? But the bottom line is I overtreat medullary thyroid cancer unlike DTC. So you treat one stage more than what is actually present. Always overtreat. But this biomarker-based risk stratification is a concept that is now followed by most centers. So it's based on calcitonin levels. So if you have more than 20 level of calcitonin, it means that the metastasis to lymph nodes is restricted to the ipsilateral central and ipsilateral lateral neck compartment. Wherever it is more than 50, that means a contralateral neck has to be, dissected. It's more than 200, then a contralateral lateral neck has to be dissected. And if it is more than 500, the level 7 has to be dissected. So you can utilize this rough guideline in deciding about the extent of operation. And so this is the concept that has, though it was around for some time, but now most centers follow this. And if you go back and follow this, you will be, have a good outcome for your patients. Again, to emphasize, the central compartment nodes are almost present in 80% of your cases. So the minimum operation for a medullary thyroid cancer is a total thyroidectomy with a central compartment dissection. Again, up to 80% ipsilateral lymph nodes may be present, and around 50% you have a contralateral nodal metastasis. So nodal burden is very high, and the reason I'm emphasizing is that the ideal operation is a compartment, and I will emphasize that in my subsequent slides. So what are the surgical options in a MTC? So if it is an occult MTC less than 1 centimeters, you can avoid doing a central dissection. So the minimum operation is just a total thyroidectomy. But for all T2 to T4, you have to do a central compartment dissection. That is very important. And based on your levels of calcitonin, you can decide about the extent of lateral neck dissections. So this is the compartment dissection that is very important, and all thyroid surgeons who deal with medullary thyroid cancer have to meticulously and systematically dissect the compartments. The ideal operation is a 4-compartment dissection for a medullary thyroid cancer. So this is a man who presented with an advanced medullary thyroid cancer, and if you see the CT scan, the lymph nodes in the mediastinum you can see here. Behind the manubrium. So we had to do a sternotomy and see the burden of disease. This was level 7 compartment, level 7, the 4th compartment, which had to be dissected. So if you have to really do, as I told you, it's a surgeon's disease, no adjuvant therapy. So you have to really take out all gross medullary thyroid cancer tissue. And so don't hesitate from doing a sternotomy in order to have an R0 resection for your patients. So this was the specimen. So you see the 4 compartments. You have a central compartment, the 2 lateral compartments, and then you have the 4th compartment, which is the level 7. Now, what happens after surgery? You have sort of, did a good clearance. There are 2 situations. One could be the calcitonin is sort of undetectable, excellent prognosis, very low risk of recurrence. And there may be a situation where, despite your good surgery, aggressive clearance, the calcitonin is detectable and patient is labeled as having a persistent hypercalcitonaemia. This is again a very important slide, and if you look at the sentence in red, somatic 918 mutation is now a very, very important prognostic factor. We have been talking about the classical prognostic factors like age, the gender, the extent of disease, the lymph node metastasis, whether you've done a complete R0, R1 resection. But the latest prognostic factor is the M918T mutation. And I would suggest that all thyroid surgeons who are dealing with MTC get your genetic study even in your sporadic MTC. And this is not, I'm talking about genetic, heritable syndromes. I'm talking about sporadic MTC having a 918 mutation. Because if your sporadic MTC patient has 918 mutation, it's going to be a very, very aggressive disease. And there are therapeutic connotations which I will cover in the subsequent. So remember, 918 mutation is very important. And now most advanced centers routinely do a genetic study even in sporadic MTC. And again, the second concept is a concept of calcitonin doubling time. Again, that is a very important prognosis. So unlike the classical prognostic factors, currently these 2 important prognostic factors are now used in practice. Again, it's always a dilemma because when you have a persistent calcitonin levels, you don't know whether it's a localized disease or it's a metastatic disease, Because if it's only a localized disease, you would like to go in and reoperate on the patient. But if it's a metastatic disease, you would like to go in for more other modalities of treatment, rather surgery. So if the calcitonin levels are more than 500 preoperatively or 150 picogram per ml postoperatively, then you should think that the patient has metastatic disease and you can go in for a PET imaging for your patient. Is that visible? Yes, I can't see it on my laptop. Yeah, so this is an algorithm which actually shows that, I'm sure you know the ATA table about your excellent response for DTC, but can I have a pointer or something? Anyway. So you can label your patient having an excellent response or a biochemically incomplete response or a structurally incomplete response. This is very similar to what is used in DTC. We have not been using for MTC, but it will be a good idea to use it in your medullary thyroid cancer patients as well. This is an example of my patient who had a pre-op value of 1500. Patient was operated. We did an R0 resection, but over the course of 5 years, patient had different values of calcitonin, and I'm sure you would have similar patients where calcitonin really doesn't come to normal, but the patient has a good quality of life. So it's kind of an indolent disease. So this is at the one end of the spectrum. So as surgeons, and we get perturbed when the patients come and say the calcitonin is not dropping. So you shouldn't get anxious. It's a natural course of the disease. If you've investigated, the patient does not have any operable metastatic disease, the patient will have a good quality of life for 10 to 15 years. Now, what should be a therapeutic approach when you are faced with a patient who has a metastatic disease? Now, certain questions come to our mind that first we have to see whether the patient is symptomatic or asymptomatic. Is the loco-regional disease controlled or not? And what are the areas of metastasis? Is it bone or lung? And whether these lesions cause any imminent threat. If, for example, if they are spine lesions, they may cause paraplegia. So you have to really see that. And what is the speed of metastatic disease progression? And that is the role of calcitonin doubling time. However, sometimes we may not have clear-cut answers for most of these questions. And so we have to fall back on our own experience or literature to really decide on a case-to-case basis how to treat these very difficult metastatic MTC patients. Now, as I told you, calcitonin helps you to define the burden of the disease, and then you can formulate your appropriate strategy. Again, to emphasize, if you have 150 picogram per ml post-operatively, then the patient has metastatic disease. And so a lot of PET scans are now available, but initially we were using DMCA scan and then FDG PET scan and then the DOTA-NOC PET scan. And so latest is that this gallium-18F DOPA PET is extremely good and more sensitive than your FDG PETs or a DOTA-NOC. So instead of DOTA-NOC, it's better to use the 18F DOPA PET scan, which are more sensitive. Again, to emphasize, whenever you are faced with such a patient, you have to really see that are you dealing with an indolent disease or are you dealing with a progressive disease based on your calcitonin doubling time. That is very important. So this is a general algorithm for your patients with metastatic disease. So those patients who are associated with high risk of complications, for example, you have brain metastasis or a spinal cord metastasis, or you have a lesion which is sort of growing into an airway. So these are imminent threat to the patient, and therefore you have to take certain measures immediately, and you have to locally control the disease. Whereas if the patient is progressive disease, then you have to consider systemic therapy, and as we were discussing, the TKIs are now the cornerstone of your systemic therapy for your patients, and two very important drugs sorry, I'll skip this. Two very important drugs were vendatinib, which was proven in the Zeta trial, and the cabozantinib in the exam trial. And after these trials, they were approved by FDA, and fortunately, they are now available in India as well. They've come within the last 2-3 years only. Now, this is the original report of the use of vendatinib in patients with locally advanced or metastatic MTCs. And based on this, the FDA gave approval to this drug, which is now the standard drug in metastatic MTC. And recently, the cabozantinib was also used in progressive medullary thyroid cancer and is also FDA. So you have two drugs for medullary thyroid cancer, which you can use as they have been approved by FDA. Now, whenever you consider tyrosine kinase inhibitors, as I told you, have to see it's a progressive disease. Is there a threat to vital structures like spinal cord or brain? Or if it's a locally advanced unresectable disease, and whether the patient is asymptomatic or not. But I'm again emphasize, sometimes it's really difficult to decide which patients to start which drug, So, but there are certain recommendations that if you have a small burden disease, you can use a particular systemic therapy. But if a patient has a heart disease, you cannot use vendatinib because of the risk of VT. And similarly, if your patient is a musician or a patient is a carpenter, you cannot use carboxanilin but use vendatinib because carboxanilin has higher risk of hand-foot syndrome. And those patients who are dependent on their hands for their profession, you use vendatinib rather than carboxanilin. So these are small, fine points where it helps you to select a particular therapy for your particular patient. So decide on a case-to-case basis and then start your TKIs. However, despite these advances in the management of metastatic disease, we have been, the literature shows that for a decade these TKIs have been around, though in India they are available only for 2 years. But the results have been disappointing, patients may respond initially, but then they relapse, The other thing is that the side effects are numerous, and sometimes, if you look at the literature, almost 40% of cases you have to stop the drug because of the side effects. Hand-foot syndrome and debilitating diarrhea, weakness, asthenia, these are hypertension and hemorrhage. So clearly we need something more than just vendatinib and carboxanilin. And it's very, heartening that now we have some wonderful drugs available beyond the TKIs. And, these are the specific RET mutation inhibitors. And that is why, if you remember my slide, you have to do your 918 RET mutation. Why? Because it helps you to select these selective inhibitors, which are now the standard of care in your advanced MTC. So if your patient is relapsed on carboxanilin or vendatinib, and you have the patient who has a 918 mutation, then you can use what is known as specific RET inhibitors. And two very, very beautiful drugs are now being used, and they have FDA approval. This is the selpercatinib, it's very difficult to pronounce all these drugs, and what is this, pralsetinib. These are specific inhibitors. So unlike the vendatinib and carboxanilin, their side effects are low, so you don't need to stop the drugs. For example, if you see the patients where drug discontinuation percentage was just 2% in selpercatinib and 4% in tralisatinib, unlike the 12% and 6%. So that is a big advantage. And second, their, response rate is much better because they are specific inhibitors of your RET. So this is the recent advance that has taken place. And I hope we have these drugs available in India sooner than later for our metastatic patients. But these two drugs are now the standard of care for your advanced medullary thyroid cancer. Rather than using multi-kinase inhibitors, you use specific RET inhibitors and have a very good response as compared to those drugs. Last couple of slides, treatment of site-specific distant metastasis. If you have brain metastasis, you can go for either surgical resection, but usually they are multiple, so you have to go for a stereotactic radiosurgery. For bone metastasis, you can utilize vertebroplasty, surgical excision. Even thermoablation has been shown to have a very good response. And of course, denosumab is a wonderful drug. Instead of using zoledronic, it's a good idea to use denosumab, which has a much better response for these patients. So it is a drug of choice for your bony metastasis, medullary thyroid cancer. For lung and mediastinal metastasis, again, not much, but you can use RFA, and laser photodynamic therapy is now useful for palliation of these patients. So just a rough algorithm, if you have a patient who has a progressive systemic disease and the patient is not eligible for local treatment, you start on vendatinib and carboxanilin. If the patient has progression, you do your RET mutation. If the RET mutation is positive, then you go for specific RET inhibitors, either of these two drugs. And this is a slightly older slide, so that was under clinical trial, but now they are FDA approved. So after RET mutation, you switch over to these specific inhibitors to have a better response. So that's about it. So a couple of slides for, so I was talking about sporadic MTC, now coming to hereditary MTC. The recent advance, and it's not so recent, is that there is more understanding of these men syndromes. And as thyroid surgeons and endocrine surgeons, we must know why these men syndromes are so fascinating. Because as surgeon, if we recognize these syndromes, then we can do an early and pre-symptomatic diagnosis. And we can reduce the morbidity and mortality from these cancers, and we can avoid surgical misadventures and missing. So it's very important for endocrine surgeons to be aware of these men syndromes. Now remember, MEN1 has the widest pleiotropy of any hereditary cancer syndrome, and MEN2, you have a very precise genotype-phenotype correlation. So if you remember these two things, then you'll be able to manage and understand your hereditary syndrome patients, MEN2A, 2B, and MEN1. Now, medullary thyroid cancer is part of MEN2A, 2B, and MEN3, but there are certain variants also. And one is the MEN2A with CLA, and the other is MEN2A with Hirschsprung disease. This is one of my patients who had a CLA variant. She had that skin patch in the interscapular region. So just a couple of pictorial depiction of our patients. A patient with 634A mutation, bilateral FEO, and medullary thyroid cancer. You can see and appreciate that the hereditary thyroid medullary is bilateral, unlike sporadic. We have a single focus. Here you have a focus in both the lobes, as you can see in this specimen. There's another family who, 3 siblings had medullary thyroid cancer, 634 mutation. This gentleman came to me for surgery for medullary thyroid cancer, but as is always done, we did a metanephrine, found to have a bilateral pheochromocytoma, and out of his 4 children, 3 had medullary thyroid cancer, and all 3 were 634 mutation positive, and all underwent curative surgery. I think all had elevated calcitonin, so it was not really a prophylactic surgery, but at least they were picked up quite early before they... So remember, MTC is the cause of death in medullary thyroid cancer, MEN2A. The cause of death is medullary thyroid cancer. So if you can, remove it early or even prophylactically, then you have a better chance of giving survival to your patients. So the concept that has come is what is known as COPS, or a codon-oriented prophylactic surgery. So it is based on the codon, your extent of surgery. So remember, you have a precise genotype-phenotype correlation, and based on that, you decide what should be the extent of surgery. So the mutations have been divided into risk categories. The highest risk is the MEN2B codon, which is the 918 codon. And here, thyroidectomy should be done within the first 3 to 6 months of life. You remember, so early you have to do. So all thyroid surgeons, may be required to do a pediatric thyroid operation for a child as early as 3 to 6 months. Whereas if your patient has a codon 634 or a 620 codon, it is a high-risk codon. And here you can delay the thyroidectomy till 5 years. It's not necessary that you do it within 1 year. And again, it's debatable whether you need to do a central dissection. What I do is, if your child is, between 5 and 10 years, you will do a CCLND. But if the child is slightly older, you will not do a CCLND, but if the child is slightly older, you would like to do a CCLND. So it's a kind of a trade-off between the age and the decision for CCLND. But there are certain codons which are low-risk codons. They have the least risk. And here, thyroidectomy can be done within 5 to 10 years, or if the patient has an elevated calcitonin levels. We don't do now stimulated calcitonin, but basal calcitonin is good enough. So remember that not just looking at the codon, but it is which type of codon is there will decide the age of operation and the extent of operation. So this is what is known as COPS, or a codon-oriented prophylactic surgery for these patients. And as I was telling, what is the point of doing a prophylactic surgery or an early surgery is that the mortality, otherwise, if you operate on a patient who already has a high calcitonin level and a thyroid nodule is there, mortality is up to 20%. But if you do an early surgery or a prophylactic surgery, the mortality is less than 5%. So you are reducing mortality for these patients. And this was the earliest paper published in NEJM, which showed that the prophylactic thyroidectomy really reduces mortality. And This was a 5-year follow-up, but subsequently a 10-year follow-up also came. And it showed none of these patients, none of these children actually developed any recurrence. So prophylactic thyroidectomy is a fantastic procedure where you reduce recurrence, you reduce mortality. And so therefore we should all be aware of this modality, and we should utilize it in our practice to offer benefit to your children of MEN2A patients. So the take-home message here is that you should remember MTC is different from DTC, and those are the points that I mentioned. Early detection is very important, and all patients of MTC should undergo MEN workup. All patients of MTC, except perhaps an elderly patient presenting with MTC, but irrespective of the age, all should have a MEN workup. Because remember, we have had patients who give history their grandfather had a solitary thyroid nodule. So it's not, bad idea to do a genetic study even in an elderly patient with MTC, so that at least the family could be picked up. It's a surgeon's disease. Surgery is the only treatment of choice. And the surgery should be adequate. That is very important. I'm very happy if my lateral neck dissection, the pathologist tells me there are 20 lymph nodes. I'm not happy if I've just removed, although it's said that 10 lymph nodes are adequate. But I'm not happy with myself if the pathologist tells you that 10 lymph nodes are the maximum dissected. Minimum 20, I'm telling you, in a medullary thyroid cancer, it has to be a meticulous dissection. And I have seen surgeons who remove just a pad of fat and don't do a good job. So it's very important. Unlike DTC here, you have to be really meticulous, remove as much as fat, really, skeletonize the entire lateral compartment, because it won't give you a second chance, and recurrence rate is very high in these lymph nodes. Again, role of prophylactic surgery in red gene mutation carries and reduces mortality, and therefore we should all resort to prophylactic thyroidectomy for your MEN2A children. Amongst this slide, I think the most important point that I emphasize is always get a RET mutation in your sporadic patients also, so that you can use a specific RET inhibitor once they develop a systemic disease or a progressive disease. So this is the kind of advancement that has taken place. And also the PET scan, as I mentioned, a gallium PET scan is the most sensitive PET scan for your medullary thyroid cancer. So I think this is the take-home message, that for medullary thyroid cancer, you have to really give them this state-of-art treatment, right from surgery to the specific RET inhibitor. Well, thank you, ladies and gentlemen, for your kind listening. I'll be happy to take questions.
I don't know, the experience with the prophylactic in India, the take-up is not so good.
Agreed.
We've had, sometimes takes years to convince them to come. 2 points. One is MEN2B. Have you ever done a child? Because what we under MEN2B is usually so bad that they don't get to the stage where they have children. So I think practically, have you had any experience?
No, I have no experience, but in literature, children have been operated.
Right. Yeah, so in our situation in India, it's very unlikely you will get into that. The second is the least risk category of MEN2B mutations, MEN2 mutations. There is an option of follow-up now. And I think even the other categories, they're saying probably we don't need to be as aggressive as we said in the initial COPs. What are your thoughts on that?
Yeah, sure. As I mentioned, in the category of the least aggressive, based on a calcitonin. So you follow, but as soon as the calcitonin is elevated, you go in for surgery. But in the other two, you have to go for a prophylactic surgery, even if the calcitonin level is normal. Because the penetrance of the medullary thyroid cancer in MEN2A is almost 100%. So except for the least codon risk, where you wait for the calcitonin to rise, I will not wait for my 634 patient. Recently, I operated on a family of 634. The 2 children were positive 634, but one had elevated calcitonin. The younger child, 5 years, didn't have. But I did a prophylactic thyroidectomy because I know that they will develop medullary thyroid cancer. So except for the least risk, rest I will do a prophylactic thyroidectomy.
Yeah, that actually reordering of that least, high and highest has happened. So everything is in the least except 634, 883 and 918. So 634 and 883 fall in the high risk and the 918 fall in the highest. So it's only in 634 and 918 you actually need to go in as in a prophylactic. Otherwise follow up calcitonin, and as you said, as soon as it starts rising, operate. Yeah.
But having said that, I must tell you that, of course you know it, that 634 is the most common mutation. You will definitely, I have not encountered a Though I have had 611 mutation, but I have never had least. So 634 is the commonest, and most practice you will see 634.
But we get 618, 620 and all, we are getting in our...
Okay. Maybe you're doing it more often. So
we are doing, all patients with MTC get...
again, I emphasize, all MTCs, please do genetic workup. That's important.
The other thing was the use of CA as a baseline. So if you've got a calcitonin of, let us say, 900, in 2 patients, but the CA is 500 in one and 50 in one, you've got 2 different sets of patients.
Definitely.
And that will sort of help you prognosticate further. As you said, it helps in prognosis, but it puts in your mind what you need to do for that.
It's sort of subtypes. It tells you before that your patient is going to behave in an aggressive manner. Okay, thank you.
Thank you, Dr. Amit, for that very interactive session and a lot of take-home messages for all of us in the audience. Now, we are not breaking for coffee, but like yesterday, the refreshments are available on the Scudder Hall at the backside, and if anybody wants, can go and have a refreshment and get back to the hall. Now, the session which was missed yesterday, the open discussion on sutureless thyroidectomy, we'll be having that session. So for that, may I invite the conveners for the session, Dr. Roma Pradhan, Dr. Navneet Tripathi, Dr. Mukta Bakshi, ma'am is here, Dr. Ro, you're the only one around, Dr. Sunil Varwa. So Dr. Sabha, shall we have it later? Okay, so then we'll move to the... Shall we just move to the debate then? Is that okay? Okay. We'll move to the next session of the day, debates in endocrine surgery. May I invite Dr. Kamal Kataria to moderate this session, please. The first topic of the debate is routine use of intraoperative neuromonitoring. 4 will be by Dr. Sudhi Agarwal, and against I will be speaking. May I invite Dr. Sudhi to please come up on stage.
Oh, very good morning to all. So after the session of this didactic lectures, very informative, now we are moving to the debate sessions. In the debate sessions, first debate is on intraoperative, routine use of intraoperative nerve monitoring. And for this debate, first I would like to call Dr. Sudhi Agarwal. She will be speaking for intraoperative nerve monitoring. And the next speaker will be Supriya Sen. So, Dr. Sudhi, please.
Thank you very much, sir. A very warm good morning to everyone. Thanks to the organizers for giving me the opportunity to present my views on this very important topic. And a special thanks to my friend Sabha, because when Sabha called me and told ki, Sudhi, you have to present on intraoperative neuromonitoring and you have to talk in favor of it, I was really banging my head, because by that time I was of the opinion, which was totally against of using intraoperative neuromonitoring in a routine thyroidectomy settings. So, but because of him, I took this task and start reading more and more about this topic, and really, like, at the end of it, I am truly in love of this technique. And I'm pretty sure by the time I complete my presentation, most of you will also start liking it and will start considering it for all your routine thyroidectomies as well. So friends, please believe me, I'm not going to go into the detailed research studies and anything, but keeping in view the people like me who don't know much about this technique, what I'll be telling very brief about the basic origin of this idea, the basic technical details, the various types of intraoperative neuromonitors, the privileges and opportunities with this technique, the conflicts regarding its efficacy, cost effectiveness, and my remarks, okay? So a strong building, we cannot build without knowing the basic foundation. So this idea originated in 1791 when Galvani initiated electricity found that the electricity initiates the muscular contraction. In 1848, Raymond measured electrical activity in muscles. 1966, Hardick developed non-invasive surface electromyographs. 1988, Lipton used wire hooks, which he placed on the vocal cord to monitor recurrent laryngeal nerves. 1996, Marmeslin used surface electrodes sited with endotracheal tubes. So this is how the things evolved. And recently, vagus nerve stimulation, which has allowed a continuous loop monitoring. So what do we monitor? We monitor mixed and the motor nerves. And why is it required? Because it helps us to identify some basic anatomical structures, some vital structures, which helps us to prevent injury. Even if injury happens, it helps us to identify it early so that we can do some corrective measures in the same sitting for training purposes and, more importantly, for medical legal safety. The basic principle lies when the nerve is stimulated, the electrical conduction goes and contracts the muscle. So the electricity, the muscular contraction, the electricity generation, that is picked up by the electrodes at the muscle level, and those are reflected on the monitor in the form of electromyography. There are two important components of electromyography. First is the amplitude. Okay? So this amplitude is the amount of electrical activity picked up by the electrodes, and it reflects how many muscle fibers are being contracted. So when we increase the electrical stimulation, more and more muscle fibers are stimulated, and the amplitude keeps on increasing. On the contrary, when there is some nerve injury or muscular injury, more importantly nerve injury, then the less muscle fibers are stimulated, the amplitude decreases. The another important point is the latent time. So what is it? It is the time taken for the electrical impulse to reach the muscles electrode from stimulation site. So if the stimulation is more proximal, the latent time will increase. The stimulation is more distal, the latent time will decrease. And similarly, any injury which either causes demyelination or decreases the nerve conduction speed, velocity, then this latent time also increases. So there are these two parameters we usually monitor whenever we look for any nerve injury. So some basic consideration, important thing we must consider while we are planning for a neuromonitoring. We should give a non-paralytic anesthesia. We should ensure that the nerve is intact preoperatively, for which we assess the nerve preoperatively by vocal cord examination. We find out that organs are already functioning, equipments are functioning, and we are interpreting in a right sense. So the various equipments are the electrodes. These are for signal acquisition at the vocalis muscle. So they are impregnated with the electrodes. Handheld probes for intermittent stimulation of the recurrent laryngeal nerve, then saxophone electrodes for permanent vagal nerve stimulation, monitor for signal visualization, and connecting cords. So International Neural Monitoring Study Group has devised the various approaches, how we should monitor a patient in which section, and some troubleshooting algorithm when there is a loss of signal. For optimal intraoperative neuromonitoring result, it is important to obtain nerve amplitudes more than 500 microvolt at baseline and use of stimulation current of 1 milliampere. We all know there are various types of injuries like transection, heat, mechanical damage by bruising or direct pressure, transection, devascularization, local anesthetic. So it's traction. You know? So it could be the main trunk or the selective branches. So this recurrent laryngeal injury can be of two types. Either it is segmental, a point is injured, or it is global, when a major portion of the nerve is injured. So this is type 1 and type 2 that we say. Segmental is less frequent because we usually more vigilant about that we are not injuring any part of the nerve. But the global, and usually it is either due to transection, electrocoagulation, pinching, which usually we take care of. But this global, that we usually don't think about it, like that we are injuring because we see that the nerve is intact, but it's actually in traction. So it is more frequent. because of the traction injury, it is more gradual. Nerve injury is mild, but it has a faster recovery that usually we see in our post-operative phases. The patient has mild hoarseness, which usually recovers. Whereas the segmental, whereas a portion of the nerve is involved, it is rapid onset, it has severe, and it has slow recovery. So in segmental, the latent time remains unchanged, but the amplitude decreases. Whereas in traction, both the latent time as well as the amplitude, it shows changes, which is called combined events. So there is a concordant change in both amplitude and the latency. Amplitude decreases, latency period increases. And when the surgeon sees that there is a combined event happening, it is required that the surgeon immediately must stop maneuvering anything which may hurt the nerve. So it should release all the structure that the surgeon is holding. And whenever the surgeon feels that it's happening again and again, it's recurrent, it's always safer to take a median route than going to the polar or the lateral dissection. Or if still the surgeon is negligent, then usually it leads to loss of signal, and which is a severe condition. So this laryngeal nerve damage is by far most serious of thyroid surgery. It not only leads to voice changes, it also leads to changes in the breathing and swallowing. So overall, the health-related quality of life is compromised. And if it is bilateral, it may lead to life-threatening complications. So the basic principle, as already told, that we usually stimulate the nerve and monitor the muscular contraction. But suppose if in the earlier phases, what we used to do is to stimulate suppose we are stimulating the distal portion of the nerve, distal to the injury, then still the muscle will contract. And it may give us a false assumption that the nerve is anatomically intact, even though it is transected. So because of this fallacy, with time, there is a phasic development in the intraoperative neuromonitoring from the intermittent IONM with needle electrodes to intermittent with endotracheal tube surface electrodes, and more recently the continuous IOM with endotracheal surface and the vagal electrodes. So this is the most recent addendum. So what are the difference between the two? Intermittent or active intraoperative neuromonitoring is surgeon's driven. So whenever a surgeon stimulates any portion of the nerve, only then we get the stimulus. Whereas in continuous IONM, it is a continuous process because the vagal nerve is continuously being stimulated. So it is not surgeon driven. So friends, we must understand that these two techniques, they are not complete in their own. So there are few advantages of intermittent, like one can do mapping and localization and can define the type of nerve injury, whether it's segmental or global, whereas which cannot be done with the continuous. Whereas in continuous, one can do real-time continuous feedback and can prevent the slowly evolving nerve injury, because like we are able to see it on monitor that the nerve is being injured. So we can immediately stop the procedure which is hurting the nerve, which is not possible with intermittent. So these two procedures are actually complementary to each other. So if we see this busy slide, and if we just find out the important points, we can see that the sensitivity and the positive predictive value of the post-operative vocal cord function is much better with the continuous intraoperative neuromonitors. The early palsy and the permanent palsy are less with continuous intraoperative neuromonitors. So overall, continuous is better than intermittent, but there are few features of intermittent which are not there in continuous. So these two, again, want to emphasize, are complementary to each other, where they both help each other so that they become a complete procedure. Okay, so this is the vagal monitor, and this is how, like, vagal monitor is also there, and intermittent probe is also there for intermittent stimulation. So this is intermittent neuromonitor prevent nerve injury by facilitating early and accurate nerve identification, whereas continuous detect nerve injury by provision of real-time feedback. So already so many associations like German and Australian College of Surgeons, they advocate use of intraoperative neuromonitor as a valuable adjunct to nerve visualization. So there are the various opportunities and privileges that many surgical disciplines now apply neuromonitors routinely. It can accurately predict post-operative vocal cord function. It has become a standard of care in many countries. Continuous IOM is the most recent addendum, and it provides for intraoperative registration of nerve signals virtually in real time. And it has demonstrated that instant release of the distressed nerve minimizes the RLN injury. For documentation purpose, this EMG recording can be printed out from the system and can be filed in the clinical chart. This is one of the very most important feature with this technique. Many surgically demanding situations like recurrent disease, locally advanced cancers, highly vascular diseases like Graves, mediastinal tumors, anatomical displacements, RLN grossly invaded by tumors like what Pooja ma'am told today. So these dissection is much easier and much safer with the use of the intraoperative neuromonitors. Another important advantage is that because this latent time depends upon the length of the nerve, so we can very well predict in which patient we may find a non-recurrent laryngeal nerve, because in non-recurrent laryngeal nerve, the length of the nerve is small. So the latent time also decreases. So we can predict in patients who have the non-recurrent nerve with the help of IONM. So there are large multi-center studies with a loss of signals in 115 nerves, and they uncovered that traction produced majority of the injuries, 60% of which took place near or at ligament of Berry. So friends, please understand that in traction injury, the nerve remains intact, but still the nerve is injured. So it again highlights the importance of the intraoperative neuromonitor. So this intraoperative neuromonitor provides a window of opportunity where we can avert the nerve injury, enables the surgical team to reflect on and change their surgical skills, and this reassurance likely reduces stress. And it also helps less experienced surgeon perform operation more safely with complication rate comparable to the experienced surgeon. Medico-legally also, it provides a documentation of the normal vagus and RLN physiology, both pre-operative and post-dissection, and which can be printed and filed in the patient chart, and it provides a strong line of defense. Since 2010, it has matured into a powerful risk of minimization instrument, firmly integrated into the thyroid surgery, routinely incorporated into endoscopic and robotic surgery. So there are some conflicts regarding its efficacy, cost effectiveness. There are various systemic studies and meta-analysis which are not supportive. But the thing is, these heterogeneous and time-conflicting results are best explained, at least in parts, by that there is a stepwise evolution of intraoperative neuromonitors. Majority of the studies, they only compared the visual identification with the intermittent neuromonitoring. So, but with time, this International Neural Monitoring Study Group has devised protocols how we should monitor and how we should change the surgical, modify the surgical steps based on the injuries identified. And now that newer and newer studies are coming up, they are comparing the visual identification with the combined intermittent and continuous neuromonitoring, which are appealing and favorable. And friends, we must confess that majority after post-operative, until unless we have a gross voice change, we don't perform the vocal cord examination. So we usually underestimate the extent of injury following visual identification. This chart is very important. I'm just going to take 1 more minute, sir. I'm about to finish. And this chart is very important, and we can see that with visual identification only, we are not able to identify whether it's really nerve injury, because we don't see the loss of signal like type 1, 2, and also we don't real-time monitor the functioning of the vocal cords because the patient is intubated. We have to wait for extubation till the time like we see that it's really injured or not. And cost effectiveness, if we see the with IOM, the percentage of nerve injury is reduced by more than 50%. So suppose if any patient, we say, who is spending thousands of rupees on thyroidectomy, we say like with a couple of extra expense, we are able to provide you much safer thyroidectomy. Do we really feel that the patient will deny using that technique? So I think it's upon us to convince the patient for that. And it is more cost effective compared to if we post-operatively patient had, we need speech therapy or laryngeal examination, vocal fold surgery, or some legal claims. So these are the various advantages that we have with the neuromonitoring. So my final remarks that neural injuries are prone to happen in thyroid surgery, though apparently small the thyroid is. It's a cause of prompt litigation. The prime function, apart from removing the tumor, is to preserve the health-related quality of life of the patient. Intraoperative neuromonitoring helps a lot in identifying and preserving the functions of the nerve. With the evolution, with the addition of continuous, now the intraoperative neuromonitoring has made a landmark in the thyroid surgery. It has, over the year, it has gathered both support and fog, and it has a lot of advantages. It modifies the surgical decision based on nerve integrity and functional. And the cost effectiveness, if adjusted for quality of life, compromise, rehabilitation, and litigation cost, is much better. Like, it's not that costly. If it's only a presumption. And a very famous quote by Martin Luther King Jr., seeing is not always believing. So it's not always that an intact nerve is with the neural physiology now that we know. All the apparently intact nerve are, it's not always that they are not injured, they may be injured. So we must believe in like the exact signals, which are the actual thing which they must have. So seeing is not always believing. And with this, I would like to thank you all for your patient hearing. And I am ready to hear from my counterpart, Supriya, about her views. Thank you very much.
Thank you, Dr. Suzy, for covering the basics of intraoperative nerve monitoring, your talk was well spotted with the evidence also. Although you have covered most of the basic aspects of the intraoperative nerve monitoring, I would like to add few points for the benefit of residents, that this intraoperative nerve monitoring, as it is not available at all centers, so most of the people, they are not routinely using it because of non-availability. As Dr. Sudhi told, prerequisite for intraoperative nerve monitoring is basically a special type of endotracheal tube is required, where the surface electrodes are there, and these surface electrodes, they come in touch with the vocalis muscles whenever the intubation is done. And beside this, we need a probe to identify the nerve, and the identification consists of two things. One is the stimulation part, another is the nerve mapping. When we are doing stimulation part, we give a current of 1 milliampere, while when we are doing nerve mapping, when we are not able to identify the nerve, then we use a higher current, 2 milliampere. So after this, I would like to call the next speaker of this debate, Dr. Supriya Sen.
Yeah, just requesting all the contestants to stick to time. There's a time limit of 10 minutes on the talk, because we need to finish these sessions.
I'll move to my topic. I'm going to speak against the norm, routine use of intraoperative nerve monitoring. Already mentioned, essentials during a total thyroidectomy is a good anatomical knowledge, optimal exposure of the entire gland, clear identification of the important anatomical structures. Risk of recurrent laryngeal nerve injury ranges from 0.5 to 7%, varied in literature, as temporary paresis, and permanent is 0.5 to 3%. The risk increases, as most of us would already know, in cases of malignancy, recurrent surgery, retrosternal goiter, toxic and large goiters. RLN nerve injury causes vocal cord paralysis, which leads to dysphonia, aspiration problem, occasionally upper airway obstruction. Now, Dr. Sudhi has already explained the various categories, how it is done. I won't go into a lot of details. It's already been explained. This picture actually shows a continuous intraoperative nerve monitoring. But before speaking against the norm, I'd just like to highlight the 4 papers on which I will be speaking. So first is this paper, which said that they were mainly done by all the thyroid surgeons. The younger generation was more happy to do the intraoperative nerve monitoring. However, there was no replacement of a visual recognition of a recurrent laryngeal nerve. So for routine surgeries, that's what the topic says, for routine surgeries it may not be very essential, and it is not a replacement for not knowing where to look for the nerve, not having adequate anatomical knowledge. Now, the second paper which I'm going to highlight here is Intraoperative Nerve Monitoring, the Proven Benefits and Limitations. So this paper mainly spoke about the like the anesthesia, though there are not certain guidelines which have been, there has been not been a lot of consensus. There are certain things everybody agrees. It has to be a short muscle relaxant like Atrac or succinylcholine to induce, and then IV anesthesia has to be given mostly in form of propofol or isoflurane, ceflurane. Now the problem with that is we know propofol is known to cause hemodynamic alterations, which is an added disadvantage in this procedure. And that can also cause, there are also added vagal stimulation, like Dr. said just now, that there can be increased stimulation sometimes when we have a loss of signal, or we need a nerve mapping, that can cause vagal side effects. The third paper is a meta-analysis on recurrent laryngeal nerve injury in thyroid surgery with or without intraoperative nerve monitoring. Now, what did this meta-analysis mainly do? It looked at all the studies. There was a very strict inclusion criteria. So what they did is they compared it with temporary nerve paralysis as opposed to permanent. So they said there is not added advantage of any significant change in the permanent nerve paralysis, and most of the temporary, quite a significant number recovered. The final the paper I am going to highlight is the operative time. Now this paper is, we have to evaluate it critically because this has told about the nerve identification and operative time. It was a comparison between 2 surgeons and the surgeries they did. Though the nerve identification time was low, they have actually not in detail put up all the operative time. So the time of the patient coming into theatre, the laryngoscopy, which is normally done directly, so making sure the ET tube is in position, the electrodes are in position, make sure that once you have exposed the carotid sheath. So there is a lot of time in the operative procedure which needs to be factored in. So this study has actually, though it has said that there is a decreased operative time, the nerve identification time is lesser as compared to the visual identification, it has not factored in the other which might be playing on the time constraints anyway. Now the most important for most of us in India, cost is even if we'd like not to admit it, cost is an important factor. So this was a US study which evaluated both the things, like doing it on a routine basis, doing it for selectively high risk, excuse me, and versus visual identification. So this, if you can see here, that is the visual identification versus this is 683 and the other one was 603, if you use it for high risk cases, where it is justified. I would still like to say that there are certain cases where intraoperative nerve monitoring has a role to play, but routine use, I'm not sure. So now we come to the main limitations of IONM. First, unavailability. Not all of us may have access to availability of IONM monitoring because it involves a special ET tube, it involves a operator box, a monitor, and also electrodes. So there might be logistic reasons in acquiring what is required for an intraoperative nerve monitoring. The second is the high cost, which I've just highlighted. High cost also, there are two things I'd like to highlight here. One is cost of the apparatus, installation, maintenance, and acquiring a special ET tube like I mentioned. But second is sometimes when you are not trained to troubleshoot your loss of signals, you might abandon a procedure thinking that you've probably injured the nerve because the guidelines say if you are not well trained, you've caused a possible nerve injury, you have a loss of signal, stop there and refer it to a higher center. So that might be a just false alarm of a loss of signal where the surgeon has abandoned the procedure and the patient has to pay again for the whole opposite lobe to be operated upon, which was initially the planned surgery anyway. The next comes to time constraints. The time, I've already highlighted that when I was describing the paper. The time to recognize the RLN might be less as demonstrated. The time taken for the whole procedure may be quite a lot, and including to rectify the loss of signal. False loss of signals have to be identified and rectified. So that might actually take up a lot of time, which factors in the operative time. For most of us who have long waiting list and most of our bigger institutions or the smaller ones, we may not have the luxury of time on our side. Now causes, what are the causes of false positive? Malfunctioning of the monitoring system. There can be errors in the operation of the status. Malfunctioning is basically the electrodes are not positioned in the right place, the ET tube placement is not correct. There is any traction of the trachea. Sometimes the most important thing which we try to avoid in an IONM is traction on the nerve. But however, sometimes traction of the trachea can give loss of signals as well. Then presence of sputum or saliva around the tube, which falsely gives a loss of signal and doesn't make the vocalis muscle stimulated when an electrical response is given. Then administration of muscle relaxants, which might be a little long acting and hence cause a false positive signal. Now, like I mentioned, the other paper which described risk of vagal stimulation. There have been cardiac arrhythmias in not all of the patients we will operate will have, ASA category 1 or 2. There will be patients with comorbidities, with associated heart problems, and we have to, and associated asthma or other comorbidities which may factor in when we do a IONM stimulation. So cardiac arrhythmias have been documented, bronchospasm has been documented, and hemodynamic alterations, especially because of the type of the anesthesia monitored, may factor in the hemodynamic alteration, not just the vagal stimulation per se. Now, lack of added value. In routine thyroidectomy, no added value when visual identification of RLN is easy. Most of us, when we know it's a routine thyroidectomy, may not need an added instrument to tell us where to look for the nerve. We know how to go about it, look for the Zucker candle, identify your nerve till the berry, trace it. And there it may not have an added advantage when you already know that the visual identification is relatively easy. And like mentioned earlier, the meta-analysis proved that there was no decrease in the permanent nerve injury. But however, having said all that, it's not that this technology is not here to stay. Obviously, a lot of us have used it in our clinical practice and have appreciated the value of it. So I would like to say not a routine use, but selective use of IONM may be very useful in our clinical practice. The high-risk cases, like I mentioned earlier, maybe malignancy when you're expecting a posterior lobe nodule, a lot of central nodes where the nerve might be embedded in the central nodes, and then IONM monitoring might help in nerve mapping and also prevention of a nerve injury. And especially when you're dissecting on the nerve, you will be further careful if you have an added device to guide you when there is a loss of signal. Then recurrent surgeries, especially when there's so much of adhesions and there is so much of inflammation, like sometimes when we go where there's a lot of inflammatory tissue also, they might be easier, not easier, but the dissection might be guided with an IONM, which might tell us where the nerve might be, because sometimes the tissues are adherent quite densely to each other. Toxic goiter, very important, may be very useful also, because toxic goiter, the nerve might be draped. Retrosternal goiter, the nerve might be posteriorly placed. If it's a large tubercle, it might be helpful in identifying. So when we do our pre-op imaging and pre-op workup, that's when we can decide if this patient will benefit from a selective use of IONM and also large goiters. I'm almost done. An unusual anatomy, like ma'am already explained, that non-recurrent laryngeal nerve. These are my references, and I'll be happy to take any questions.
Thank you, Dr. Supriya. As Dr. Sudhi told, it is a very difficult topic because intraoperative nerve monitoring, it is a new addition in surgeon's armamentarium. So not many studies are available in literature. Most of the studies are either in the form of observational studies. Very few randomized trials are there, which are either having a very small sample size and the follow-up is not well planned. So with this paucity of evidences in literature, even then, both of the speakers, they put their point and well spotted with the evidence. And what is the need of the time is that we need a well-designed, well-analyzed, randomized trials who are having a large sample size, well-planned follow-up. Only then we will be able to say that a routine use of intraoperative nerve monitoring is useful, added benefit. But till now, intraoperative nerve monitoring use is limited to, as told by Dr. Supriya, these recurrent malignant tumors, large MNCs, and the toxic goiters. No doubt, here in these cases, intraoperative nerve monitoring is quite useful. But routine use, still we have to prove it, the routine use of the intraoperative nerve monitoring. Thank you for both speakers. And the topic is open for discussions.
Yeah, so I've been using neuromonitoring for the last 10 years, and I'm happy that I was perhaps one of the first few surgeons in this country to use it, and I've trained a whole generation of surgeons in neuromonitoring. Now, there may be randomized trial and no, firm conclusion, but I'm telling you from my own experience. Besides these cases, see, unless you have a tube in place, you will not know whether you are going to encounter a difficult nerve. So you've lost that opportunity, number one. Number two, there are even an experienced surgeon like me, at times, I find there are a few fibers I'm unable to differentiate between the nerve, and neuromonitoring has helped me. Besides those difficult cases, locally advanced thyroid cancers, large goiters, I operate, and everybody does, on patients who have been operated elsewhere with a nerve palsy, gives you a fantastic. I find no reason not to use a neuromonitoring. As far as cost is concerned, you already use shears, harmonic, one can argue what is the advantage. So it's all upon refinement of surgery, precise surgery. You are improving results from 98 to 99%, So you can argue either way that it's only 1% increase or benefit, but that benefit is huge for the patient. So I think this is one gadget which probably all thyroid surgeons should have it. You can't foresee in which situation you will encounter a difficult nerve. And you will get difficult nerves even in routine cases, I'm telling you. So it's always good to have a tube in situ and you can do a neuromonitoring, Not only that, at the end of surgery, you're leaving behind a functional nerve with the help of neuromonitoring. You're not leaving behind an anatomically intact nerve. If you don't use neuromonitoring, you're leaving behind an anatomically intact nerve. But by the use of neuromonitoring at the end of your thyroidectomy, you're leaving behind a functional nerve. That's very important, So I think definitely this gadget has to be used by all thyroid surgeons, especially novices, those who are occasional thyroid surgeons. I'm not experienced. Occasional thyroid surgeons definitely will find this tool very, very useful because they are not used to dissecting the nerve and visualizing the nerve as Dr. Supriya may be experienced, but occasional thyroid surgeon may not be. So for both occasional and for experts, this is a very good adjunct, definitely. Thank you. I don't have much experience. I think in this hall, perhaps Roma would and Pooja would have the maximum experience. So let's hear from them.
Thank you, sir. For continuous neuromonitoring, actually, we have that machine, but we are not using it routinely because we have certain issues. Like one, we need good assistant for the proper attraction, because you have to identify the vagus. And if you don't have good assistants or residents are doing on their own, they may injure the IJV. So unnecessarily, we have more complication of damaging the IJV, finding out the vagus and putting that clip on it. So that is an extra thing. Plus, it involves a lot of extra time, setting up the machine, then any connection is proper or not, the vocal cord, the tube, that electrode is sitting on the vocal cord or not, it is snugly fitting or not. The anesthetist has to put one size extra tube so that it snugly fits the vocal cords that point. If they put the right size or one size smaller, then we have a problem. So if the circuit doesn't set up, then we can't use it. Then you have to keep looking at the monitor. If you are doing continuous throughout, every few minutes you have to look. So instead of operating, you are more focused or stressed looking at the monitor. So we realize a lot of issues are there. So we selectively use when it's really needed. We don't use as a routine because we realize as a routine it's not helping us. Plus continuous has got that you can use as intermittent also. So if we are really stuck, we may use intermittent probe instead of continuous, but continuous involves a lot of other trouble. It's a troublemaker also. So use it if it is really helping you.
I really well appreciate your points, ma'am. What I feel, most of our points is related to like our experience. The more and more we operate, the more experience we'll gain and less time, less complexities, because then we gradually become more tuned to this technology. So it is more related because it's very new to all of us. Majority they still don't use, and those who are using, those are also new to this technique. So it is one of the major factors. So this learning curve, as soon as it is surpassed, most of the complications will also come down.
One thing I would like to mention for continuous neuromonitoring is the amount of traction that we give to the nerves while we are operating. So we just come to know with the use of continuous neuromonitoring. We might not be, we are actually speaking, the nerves do not speak for themselves, but continuous neuromonitoring actually speaks for the nerve. So the signals that we get, so we are a little careful. Yes, we need to stop this step and apply less traction to the nerve. I mean, we all do that, but especially for dissecting near the nerve, I think it's really helpful.
There's a very interesting paper on continuous neuromonitoring. And during a thyroid surgery, there have been at least 50 events when the nerve was put under traction. We don't realize when we operate how much traction we are putting on the nerve. So really continuous neuromonitoring, and as really a learning curve is there in everything. You know, once you've crossed that learning curve, it's a very simple, you will find it very simple. It takes 5 minutes to dissect the carotid sheath, put in the APS probe, and then you can start continuous neuromonitoring. So there's a red lines where amplitude and voltage is there, and as soon as it goes beyond that, latency is increased or amplitude is decreased, it gives you an alarm. And you realize that you are really playing with the nerve, you know. It's a very strong nerve, that is why we don't get injury, but we really do everything to damage the nerve while doing even a routine thyroidectomy.
Thank you for the session. And now we move to the next debate. For that, may I invite Dr. Deepak Abraham to moderate this session. The topic for the next session, next debate is persistent hypercalcitonemia, observe versus intervene. The speaker speaking for the norm is Dr. Ramya, and against the norm is Dr. Dhrithiman. So now may I invite Dr. Ramya to speak for the norm.
So I think just to lay down 10 minutes for each speaker, and we would have a 2-minute time for rebuttal for each of you. Yeah.
Good morning, everyone. I'm excited to present, especially before Dr. Deepak Abraham was done PhD in MTC. I'll be talking in support of observation in persistent hypercalcitonemia in medullary thyroid cancer. As we have seen in the previous lecture, MTC is a very rare differentiated thyroid cancer which originates from parafollicular C cells, and it is characterized by early lymphatic and early occult systemic spread, and the prognosis is intermediate between very well differentiated PTC, FTC, and anaplastic. So surgery at early stages is the only effective treatment, and luckily we have biochemical markers like calcitonin and CEA, which in the preoperative setup can indicate the stage of disease and can guide the extent of surgery, and in postoperative setting may help in follow-up, determining the cure, and may help us in identifying early detection of recurrence. So before even going to the topic, what are the basic tenets to label one as persistent hypercalcitonaemia? So first of all, there obviously should be elevated preoperative calcitonin, and the persistently elevated postoperative calcitonin, whether it should be above normal limit or detectable is debatable. And it all must be understood in the context that what was the intent of surgery before operation, whether it was curative versus palliative. And it is important to determine the adequacy and completeness of the first surgery to understand further what to do with this that we have got, with the report that we have got. Because it can help us to identify aggressive disease and can guide us in further management. So 30 to 55% of macroscopic medullary thyroid cancer patients undergoing curative resection have seen to have persistent hypercalcitonemia. And these patients are seen to have higher recurrence rates, and they have decreased survival compared to the patients who have complete biochemical cure. And the prognosis depends primarily upon the age and extent of the disease in these patients at the time of initial surgery. Because as we have seen, the earlier we detect the case, the limited the disease is, and the surgery is going to be more complete. So in a study done which had looked at epidemiological factors, prognostic factors for survival and for biochemical cure in MTC, which is one of the largest studies done from a French group. It is a retrospective analysis from a French national registry specifically for MTC. Younger age at surgery and absence of lymph nodal involvement were predictive of biochemical cure. And the 10-year survival in these patients with incomplete disease was 70% compared to 98% in patients who are cured. And the 5-year survival, as we see, is not much different. Of course, the 10-year survival was 70 versus 98, whereas 5-year survival is almost comparable. So the survival, they have concluded from this study that survival in MTC patients appears better than expected, even if it is in biochemically non-cured patients. And considering the strong impact of stage, the necessity for preoperative diagnosis of MTC is obvious. So we have to first understand that there's no proper accurate definition for persistent, biochemical incomplete cure. Some have taken it as less than 10, and the others have taken it as just below the upper limit of the normal test value, and some have taken it as undetectable calcitonin, and others have some have evaluated immediately after the surgery within a week, and some have taken 3 months. So among patients with biochemically cured MTC, those with undetectable or normalized calcitonin concentrations have different risk of recurrence. So it is important to even consider